So as you can see from your program, we've got three really interesting speakers this morning, leading off with Dr. David Dunn. And David is the QAAMS Clinical Support Officer, and I first met David back in around about 2002 when he was the Medical Director of Bega Gumberungu Aboriginal Medical Service in Kalgoorlie, and I've always been impressed with David, sort of his quiet manner, but he's so professional and so knowledgeable, and really has the interest of Aboriginal health at heart. So we're really pleased that David accepted the role of being QAAMS Clinical Support Officer a number of years ago, and we've appreciated his contributions to the QAAMS team and the QAAMS workshop over many years. So David today is going to talk to you about diabetes and kidney disease, and I hope you all enjoy his presentation. So I'll hand over to David now. Thank you very much.
Thanks, Mark, and thanks for the invitation to talk today. First of all, I'd like to acknowledge the traditional owners of the land that we're meeting on and pay my respects to elders, past and present. It's always a joy for me to be involved in the QAAMS workshops because, I see all these fantastic, enthusiastic, committed health workers and other workers, and the enthusiasm is just infectious. And I guess, that's what working in Aboriginal Health Services is about as well, isn't it? It's about commitment to our patients. So it's great to be here, and it's great to be in Darwin as well. I was telling some people yesterday that, and it's a frightening thought, that the last time I was in Darwin was 25 years ago, and I was actually working then at the hospital, and I can't believe where that time's gone. So, as Mark said, I'd like to talk to you about diabetes and kidney disease, and particularly about the role of Aboriginal health workers in the management of those conditions. So I've been working in community controlled health services since 1991. So I was working at Bega Gumberungu in Kalgoorlie until 2004, and during that time I was involved in working with health workers in the rural and regional areas, but also remote areas of Western Australia, including Junjunjara, and I know we've got someone there here today. That was exciting to meet them yesterday. But for the last 10 years I've been working at Nyanti in the CBD in Adelaide, and when we left Kalgoorlie I was wondering how things might change for my work when we moved to Adelaide, and the truth is that in some ways things are not that much different in terms of the problems that we encounter with our clients. Of course there are some major differences, but that urban perspective is one of very real need as well. So I guess the key theme running through my talk is that I really appreciate the key role of Aboriginal health workers in caring for our patients, and I know that when health workers clock off at the health service, they actually haven't clocked off from their role. So, you might get a knock on the door at 10 o'clock at night, someone coming round with a sick kid or whatever. You're on 24/7, that's it. That's your role. And I think that's something that really needs to be acknowledged. And I guess the theme of my talk is that I don't want to give it all away, although we might be able to finish it a bit sooner than 45 minutes. But Aboriginal health workers are just vital in the management of diabetes and kidney disease in our patients. So as we all know, diabetes is incredibly common amongst our patients, and so the data says that it's 3 to 4 times more common in Aboriginal and Torres Strait Islander patients than non-Aboriginal patients. and they say that overall the rate amongst Aboriginal and Torres Strait Islander adults is around 20%, but all of you will know that this varies widely across communities, and there are some communities in which there are rates of more than 50% of adults with diabetes, so you don't need me to tell you that it's a huge issue. And in remote communities, the problem is even greater. So amongst our patients, we see people with diabetes much earlier than non-Aboriginal patients, and sometimes we're seeing teenagers and even sort of kids presenting with diabetes. So it is something that is becoming more common. And the kind of diabetes that we see is type 2 diabetes, and obesity is often a feature of that. So, as you would all know, in type 2 diabetes, insulin, which normally works to push sugar or glucose into the cells, particularly in muscle and liver, insulin doesn't work as well as it should. And so that means that sugar is higher in the blood because it can't get into the cells. And that's sort of the basic thing that's happening in type 2 diabetes. And the common presentation that we see is what they call syndrome X. I'm not sure if you've heard of that. You probably have, because there is a lot of discussion about syndrome X, and really all that means is that patients often present with a few things together. So as well as high sugars, high blood pressure is a common thing that goes with it. The fats in the blood are often up as part of that picture, and as we said before, obesity, particularly central obesity, so a large waist, is a common scenario that we see. So, Aboriginal health services have been leaders and are leaders, have been leaders for years in important work in screening our patients. And one of the main drivers for that, of course, is trying to detect diabetes, but also to find elevated blood sugars before someone actually gets to the point of developing true diabetes. Because that gives us the opportunity, if we find someone with what they call pre-diabetes, which is just a mildly elevated blood sugar, to work with them to try and stop them developing diabetes and stop them then going on to develop complications from diabetes. So screening is critical because, as you know, often patients have no symptoms from their elevated blood sugars, and so they don't realise that something's up until later. So I really encourage you in the fabulous work that you do in screening your patients, because it's so important. So, as I was saying, really what we're interested in is trying to stop our patients going on to develop the complications of diabetes. So, I had a look at the most recent general practice guidelines booklet recently when I was preparing for this talk, just to look at what's the latest on how you diagnose diabetes. Well, I know from my experience, and I'm sure it's yours as well, that the usual thing is someone comes in, the health worker checks their sugar, and it's 20. And you think, oh, okay, they've got diabetes. But just looking at the books, there are a number of ways of diagnosing diabetes. So a fasting sugar of more than 7 is diagnostic. And as I was saying, then a sugar greater than 11 is diagnostic of diabetes as well. but interestingly, also an HbA1c of greater than 6.5 is diagnostic of diabetes. Now, of course, as you know, through the QAAMS program, we are able to claim a Medicare rebate for HbA1c testing, but that's only for monitoring diabetes, not for diagnosis. So in Australia at the moment, we're not, well, certainly not where I'm working anyway, and it's not funded for HbA1cs to be used for diagnosis, but it is in the Australian guidelines and that, which is interesting. So I guess, you know, the pressure's on the government, and hopefully that will change in terms of the funding to be able to do HbA1cs for diagnosis. So I think that's something that's coming. Diagnosing pre-diabetes or impaired glucose tolerance, well, that's when the sugar's between 7.8 and 11. And that's important, trying to catch it before it develops into diabetes. So this list of risk factors for diabetes is critical, because if we understand what the risk factors are, then we can, just in our own minds for a start, think about, you know, if we see a patient who is overweight, who's smoking, who's not doing much exercise, we think, oh, I wonder if they've got diabetes. So that's the first thing. But the other thing is, if we know those risk factors, for the ones that, there are some that you can't change, like your gender or your age, but there are a number of, like, a lot of those risk factors are modifiable, which means you can change them. So if we're aware of those risk factors that we can change, then we can work with our patients to either prevent them from developing diabetes or to help them better manage their diabetes. So I just wanted to show you this. You've probably seen it before. So this is the diabetes screening tool, and you can get hold of this on the Diabetes Australia website. And I think it is actually a really useful sort of thing that you could use in your clinics with your patients. It's like a questionnaire for patients that you can run through to look at their risk of diabetes. And so the questions are at the top, your age, and so the older you are, the more points you score in terms of risk. Gender, I must admit I learnt that men are at more risk of developing diabetes when I was preparing for this talk. I didn't know that. There you go, it's a worry, isn't it? Been working in the area for long enough, I should have known. Aboriginal people are Aboriginal and Torres Strait Islander people are at higher risk. And then it asks about family history. So that's a really important pointer as well, if someone has a family history. And of course, for many, if not most of our Aboriginal and Torres Strait Islander clients, a family history of diabetes is something that is there. And of course, as health practitioners, we need to be mindful of how we ask about family history, because of course, because of stolen generations issues, some people may not know their family history. So you do need to be careful about how you ask about that. Whether the person has had a high blood sugar in the past, random sugar, that puts them at higher risk. Whether their blood pressure has been up, whether they're a smoker. So smoking is a really, really important issue. It is a risk factor for diabetes, and we know that smoking rates amongst Aboriginal and Torres Strait Islander people are much higher than the general population, and they're close to 50%. So I mean, smoking has many, there are many health effects of smoking, but diabetes is one of them. So that is something that is important to raise with your patients. How often, so looking at diet and how often you eat fruit and vegetables is another question there to assess risk, and eating fruit and vegetables every day is a protective factor against diabetes. And then the next point there is around exercise, and the current recommendations are that, I mean, on this questionnaire they look at whether you're getting 30 minutes of exercise 5 days a week. The current recommendations are 30 minutes of exercise every day. But I guess the bottom line is being physically active regularly is really important in terms of protecting against diabetes. Also there they have the waist measurement, and that's another sort of indicator of risk of diabetes. And on this form here they have the measurements there for Aboriginal people of waist, and it's different to non-Aboriginal people. Aboriginal people, non-Aboriginal people are a bit fatter, and in terms of their sort of normal body weight, that's what they say. So for an Aboriginal man, a waist circumference of greater than 90 centimetres, so that's measuring around at the belly button level. Greater than 90 centimetres puts you at a higher risk, and then more than 100 centimetres puts you at even higher risk. But anyway, I think it'd be worth having a look on the Diabetes Australia website at this resource, and there are some other fabulous resources there as well. I'd encourage you to have a look at that and see. You might be able to adapt it to make it more appropriate for your service as well. So then at the bottom you add up the number of points that have been scored by going through it, and it gives you a 5-year risk of diabetes. They actually say that this tool may underestimate the risk of diabetes in Aboriginal people, but I think it is a good, useful thing, because it just gets your head thinking about those risk factors that we need to deal with. So the reason that we are so keen to manage diabetes carefully is to try and avoid complications. And this graphic just sort of shows the major complications. So those are cardiovascular disease, which is heart attack and stroke, and peripheral vascular disease, which is making the arteries narrower, particularly to the legs. Diabetic eye disease, so cataracts are more common, and also effects on the back of the eye, or retinopathy. And neuropathy, I'm sure you all know patients who have numbness in their feet or shooting pain in their feet from diabetes, and that's part of the neuropathy picture that we see. So today I wanted to talk more about diabetic kidney disease, and that's another possible complication from diabetes. So diabetes is the main cause, the leading cause of chronic kidney disease and end-stage kidney failure. And as it says up there, Aboriginal people have much higher rates of end-stage kidney disease, and once again rates are highest in remote areas. Now, I just wanted to show this really brief animation. It just talks briefly about the function of the kidneys.
Kidneys filter blood and make urine. Blood passes into the kidney through the renal artery and returns through the renal vein. Once inside each kidney, the blood passes into capillaries and then into thousands of tiny structures called Bowman's capsule. Here filtering begins. The blood is under high pressure. Water, the waste molecule urea, and other small molecules pass out of the capillaries and into a kidney tube, called a nephron. Now the liquid is processed. The coiled part of the nephron makes sure that glucose doesn't escape into the urine, and the loop of Henle makes the urine concentrated, so that water is conserved. There are thousands of nephrons, each making urine. The liquid drains into the central part of the kidney and then flows down the ureter.
Okay, so the basic message from that is that an important function of the kidneys is as a filter, so filtering out products and fluids from the blood. And kidneys maintain our proper fluid balance and the proper amount of salts and acids in our blood. So I think, most people know about that, but there are other really important functions of the kidneys as well, and when kidneys get sick, these can be compromised. So the kidneys make hormones, which are proteins, which are really important. So erythropoietin is one of those proteins, and that's important in keeping blood strong, so in the production of red blood cells. Renin is another protein, and that's involved in blood pressure control. And active vitamin D is also made through the kidneys, and that's important in keeping bones strong. So there are a number of really important functions of the kidneys. So similar to the discussion about risk factors of diabetes, risk factors for chronic kidney disease, there's a lot of overlap. So you can see there that diabetes is at the top of that list. High blood pressure, and smoking, once again, is really important. There have been studies done showing that babies that are born small become adults who have higher risk of chronic kidney disease. So nutrition is really important. Recurrent skin and throat infections also are a risk for chronic kidney disease. And linked with that, of course, are poor living conditions and poor health hardware, so particularly in remote areas, problems with having access to clean running water and having adequate shelter and adequate living conditions are all playing into this. And once again, obesity, physical inactivity, as with diabetes, are risk factors for chronic kidney disease. And a family history is important too. So cardiovascular disease runs at about 10 times in Aboriginal and Torres Strait Islander people, runs at about 10 times the rate of non-Aboriginal people, and this is a really important risk factor for chronic kidney disease as well. So, looking at the Diabetes Australia website, again, I found this fabulous resource, which I'm wondering if anyone in this room was involved in developing, because I saw it sourced from NT Renal Services. I think it's excellent, and so yeah, I'd encourage you to have a look and see whether you think this might be appropriate to put up on the wall in your clinic. It just outlines in a really graphic way the risk factors for chronic kidney disease, and I think it could be very useful for talking with our patients about that. So, as with diabetes, screening is really important for kidney disease, because kidney disease, patients don't develop symptoms from kidney disease until they're way down the line with the disease. So kidney health screening, or a kidney health check, is a really important concept and important for health workers to be involved in. So this comprises of 3 components: a blood test, and we'll talk about each of these in a minute. So a blood test, So we can measure something called the EGFR, which is a measure of the filtering ability of the kidneys. A urine test, which is the ACR, which if you're not familiar with it yet, you will be by the end of the day, because I know there's some training sessions on that, and that's a really important QAAMS test, and the blood pressure check. So these three things, as well as checking weight and thinking about risk factors, are really important in terms of doing a screening for kidney disease. And it's recommended that people with diabetes or high blood pressure should have this check done at least every year. And for Aboriginal people over 30, the guidelines say that every 1 to 2 years should be done as well. And once again, I found a great resource on the kidney health check. I think it's, I thought this was excellent. Okay, so the GFR, that's the glomerular filtration rate, and basically that's just a measure of how well the kidneys are filtering. And so the blood's taken and the lab will calculate this number by also looking at the age and the gender of the patient, because the way the kidneys filter is dependent also on your age. It drops off as you get older and also on your gender. So that's a useful number that we get back from the lab telling us how the kidneys are going. So a number greater than 90 is normal, but an EGFR of less than 60 for more than 3 months means the person has chronic kidney disease. And then as the filtration rate drops down, then the patient will be sicker, and by the time it's down to less than 15, that's when the patient will be needing dialysis. So, as I said before, patient may have significant kidney disease without any symptoms, so they might lose more than 90% of their kidney function before they actually get any symptoms, and that's why screening is so important. Okay, and looking at the next component of the kidney health check, the ACR. So this is really important because the ACR enables very early detection of kidney disease. So the ACR, if it's detected early, a rise in ACR, if that's detected early, then studies have shown, and we see with our patients, that if we treat them for their high blood pressure and with the appropriate drugs, which are ACE inhibitors, that's what the drugs that have been shown to be very effective, we can actually reverse this kidney disease. So it's really important to try and pick this up early, and we can actually pull it back to normal. So the ACR is looking for, I tell my patients that the diabetes can make the kidneys leaky, and so what we're looking for is tiny amounts of protein that are getting through into the urine when the kidneys are leaking, and that's what the ACR test is looking for. It's looking for albumin, microalbuminuria, which is just tiny amounts of protein in the urine. And the more protein that's in the urine, then the worse the leakiness of the kidneys and the worse the kidney disease is. So ideally, the ACR is done on a first morning specimen, but often in clinics we will just do it when we've got the patient needing to check it out. It's important that there's not a urine infection, because that will change the reliability of the ACR. So you would do a dipstick in the urine to first check that there's no signs of infection before proceeding to an ACR. As well as predicting kidney disease, ACR predicts cardiovascular disease, so heart attack and stroke. So it is a really important measure. And so, as we said previously, for people with diabetes or high blood pressure, we should check the ACR yearly. And if they do have an elevated ACR, it should be monitored every 6 months. Okay, so in summary, what we've said is that in chronic kidney disease, the kidneys are not filtering as well as they should, and the waste products, particularly creatinine, which is a breakdown product from muscle, builds up in the blood. And so the filtration rate goes down and the waste products go up. The kidneys become leaky and they let protein through into the urine. And the body sort of fluid balance gets messed up. So this is a bit technical, but I thought I should put it in. Basically, it's saying that if you have albuminuria, or proteinuria, so protein in your urine, or your filtration rate is reduced below 60 for 3 months, then that's what they would call chronic kidney disease. This is a chart. I hope you can see it. It's a bit, it's not that easy to see, but I don't know if you can see this line here. This is actually just a photo of my screen at work of a patient, one of my regular patients, who's a 70-year-old Aboriginal woman who's had diabetes for many years, and she gave me permission to show her graphs. They are de-identified, but you can see here, this is the graph of her ACR, and over the last couple of years her kidneys have been getting worse from her diabetic kidney disease. We've been measuring her ACR, and you can see how it's sort of been going up. So this is from Communicare. This is another Communicare screen, which shows her creatinine, and that actually recently has been going up as well. Unfortunately, Communicare, the way we've got it set up, doesn't plot the EGFR. I would have liked to have been able to show you that, but I can tell you that unfortunately has been dropping down recently, and it's currently around 35. So when the kidneys become sick, those other functions are affected as well, and so the blood will become weak because the erythropoietin protein is not produced. Bones also will become weak because the active vitamin D is not produced, and so people with worsening chronic kidney disease are at higher fracture risk, and also their blood pressure goes up because that other hormone, the renin, is not being produced. So there are a number of health problems that happen from worsening chronic kidney disease. So the ACR and GFR, as they change, as the ACR goes up, more protein in the urine and the filtration rate goes down, the risk of dying related to kidney disease goes up. That's actually mostly from heart attack and stroke, rather than from the actual lack of filtration and other kidney problems. So you would all have seen patients who are very sick from end-stage kidney failure, and they are very sick, and this is obviously what we're trying to avoid. And these treatments are those which are used for end-stage kidney disease, dialysis, transplantation, although that of course is at a pretty low rate, and just using medicines really only is a very temporary measure. We're trying to avoid people getting onto dialysis. So the key is prevention, and so in terms of diabetic kidney disease, I know this is pretty obvious, but I'm going to say it anyway. trying to prevent diabetes is a really important thing, of course, to prevent diabetic kidney disease. So not only prevention, but detecting that pre-diabetes phase, so then that gives us the opportunity to try and stop the person from pull it back, or even detecting early diabetes, so then we can get their sugars better under control. Because we know that if blood sugars are poorly controlled, then there's a higher risk of diabetic kidney disease developing. If we can improve the sugars and have them tightly controlled, then that reduces that risk. So doing the kidney health check with the ACR and eGFR is important, and good blood pressure control is critical as well. So for our patients with diabetes, we're aiming for a blood pressure of at least 130 on 80, but depends which specialist you talk to, but I think the bottom line is, if you can, the lower you can get the blood pressure without the patient being getting dizzy and having symptoms, the better, really. And stop smoking, is a critical thing that we should never forget. And in terms of slowing the progress of diabetic kidney disease in your patients who already have diabetes, it's really the same thing. And as I was saying before, the use of those medications like perindopril, lisinopril, the ACE inhibitors, they also have a cousin family of drugs called ARBs, which are also related to people who can't take the ACE inhibitors. Those medications have been shown to reverse diabetic kidney disease, and at least, if in some patients it doesn't reverse it, at least stabilise it. And interestingly, although the number of people worldwide with diabetes is increasing exponentially all the time, with better detection and better treatment for diabetic kidney disease, the number of people who are getting to end-stage kidney failure has stabilised worldwide, and in some studies has actually dropped off. So it shows that appropriate treatment is really important, because we do have the potential to stop people ending up to need dialysis. So it's really, really important. So I just wanted to finish with a quick, not sure if we can do it in 4 minutes, but I'll try. A quick case study. This is a patient who I just made this up, but it's a typical scenario of what I'm sure all of you see every day in your work. 38-year-old Aboriginal man who presents to the health worker. He comes in because he wants a checkup, and the health worker, of course, is thinking, okay, well, why is he coming now? He hasn't come in the last 5 years. And so you get chatting with him, and he tells you that he's coming because his brother was told 2 weeks ago that he will need to be on dialysis soon. So the health worker then thinks, okay, well, I need to take a history and look at this patient's risk factors for kidney disease. And so you can see this man has no past medical history, so he's not known to be diabetic or have high blood pressure. So that's a positive. He's a smoker, so that's an important risk factor. He doesn't drink alcohol, and that's actually really important too, because excessive alcohol consumption is a risk factor for kidney disease. He doesn't get much exercise, he's a truckie, and he buys pies and pasties and other fatty food from truck stops, and that's what he eats. So his diet is pretty terrible too. He's got a really strong family history of diabetes, and this is a very common story. So the health worker then goes on to do what you guys normally do in your clinic. So check his weight and height, his BMI is 35, so he has obesity. His waist circumference is over 100, so that puts him at risk of diabetes, just thinking of that risk chart that we looked at before. His blood pressure is up at this time. It may be just that you're a really scary person and he's got, white coat hypertension, so he's worried, so you get him back and check his blood pressure a couple of times later just to see whether it really is up or not, but it may be. Okay, and you can tell from that blood sugar of 13 from what we were saying before that because it's more than 11, that's diagnostic of diabetes. I would get the patient also to just wash their hands and repeat it, because sometimes you get these random sugars that are sky high, and I think they maybe just had some Coke or an orange or something and it's still on their fingers. So I'd recheck that, but it looks like he's probably got diabetes. His urine doesn't show any signs of infection, so the health worker, given that it looks like he's got diabetes, goes on and does an ACR. So his ACR on this occasion is 10, so greater than 2.5 for men is elevated. So it looks like he might have microalbuminuria. And his HbA1c is 9%. So we're aiming for, well, on the previous, what we were saying before, greater than 6.5 is diagnostic of diabetes. And his cholesterol and triglycerides are up as well, that's in his blood. Okay, so this is the sort of problem list that we're looking at, and I know that this is nothing remarkable, like these, our patients commonly have this sort of list. In terms of his ACR, it would be important to recheck that on an early morning specimen to check whether it really is up. This is the list of medical issues. So, just in about a minute and a half, we'll just quickly run through your approach to a patient like this. And I guess, the important thing at the first consult, of course, is to develop a relationship, try and develop a relationship with the patient so that he feels comfortable to come back to you, because you need to explain to him that diabetes is something that is going to need to be followed up in an ongoing way. You need to explain diabetes to him and the possible complications, and then work with him to try and improve his blood sugar levels. So diet and exercise are the first things that we need to be thinking about, and considering involving his family in that could be useful as well. Have to talk about the truck stop diners as well, I think. And then the doctor might go on to prescribe medications for him, and of course, checking that he's signed up to the Close the Gap PBS co-payment scheme is important, so he does actually get his medications at a reduced rate. And as we said, if his blood pressure is really up, using an ACE inhibitor to control that. And then stopping smoking, of course, as I've said a few times. And then just thinking back to what we've talked about over the last 40 minutes or so, the need for those ongoing checks as you move forward with this patient is really important. And of course, the other things that we routinely check for our patients with diabetes, including their feet. And I know a number of you are taking retinal photos with fundal cameras, checking his eyes for diabetic problems is also important. And then I think the final thing is just considering whether members of his family should also be screened for diabetes and kidney disease. So, thank you for listening, and I hope that this has given you some more confidence and enthusiasm to go back and work with your patients. And yeah, I'd like to thank you all as health workers for the fabulous work that you do. Thank you.